You're listening to Concepts in Psychiatry, the premier podcast for psychiatrists, psychiatry residents, and other mental health professionals interested in strengthening their knowledge of the fundamental concepts of psychiatry and learning the latest news in the treatment of mental health disorders. I'm your host, Dr. Sarah DeLeon, a third-year resident in psychiatry, and this is episode 10, originally airing on January 29th, 2018. Today's topic is the management of acute alcohol withdrawal. If you'll remember, on our last episode, number 10 from December, we covered alcohol use disorder, including evaluation and management of this condition. Please refer to that episode if you're interested in information on alcohol use disorder itself. First, let's talk about the epidemiology of acute alcohol withdrawal. As previously discussed in episode 10, in the United States, the 12-month prevalence of alcohol use disorder is estimated to be about 4.6% in teenagers and 8.5% in adults. However, the prevalence of alcohol use disorder in hospitalized patients is estimated to be as high as 40%, and about half of those patients with alcohol use disorder will experience alcohol withdrawal with a reduction or cessation of alcohol use. Most individuals do not experience significant withdrawal symptoms. However, withdrawal is common within the emergency department and medical and surgical inpatient units. While most alcohol withdrawal is mild, an estimated 10 to 20% of patients will experience more severe withdrawal symptoms, and this can include hallucinosis, seizures, and delirium tremens. These can be a reason for admission to inpatient hospitalization as well. The DSM-5 defines alcohol withdrawal as a cessation of or reduction in alcohol use that has been heavy and prolonged, and B, 2 or more of the following symptoms developing within several hours to a few days after the cessation of or reduction in alcohol use as described in criterion A. The symptoms could be autonomic hyperactivity such as sweating and tachycardia, hand tremor, insomnia, nausea or vomiting, transient visual, tactile, or auditory hallucinations or illusions, psychomotor agitation, anxiety, and/or generalized tonic-clonic seizures. Other criteria include that these signs or symptoms are causing clinically significant distress or impairment in social, occupational, or other important areas of functioning. And lastly, the signs or symptoms are not attributable to another medical condition and are not better explained by another mental disorder, including intoxication or withdrawal from another substance. There is one specifier present in the DSM-5 for alcohol withdrawal, and that is with perceptual disturbances. This applies to the rare cases where hallucinations occur with intact reality testing or when auditory, visual, or tactile hallucinations occur in the absence of a delirium. There are a number of genetic and environmental factors that interplay to contribute to medical and psychiatric conditions, and alcohol use disorder and subsequent withdrawal is no exception. The probability of developing acute alcohol withdrawal is increased with an increasing quantity and increasing frequency of alcohol consumption. Most individuals who experience acute withdrawal are drinking on a daily basis, and they are consuming 8 or more drinks per day over multiple days at a time. Individuals at increased risk also include those who have multiple concurrent medical conditions, who have a family history of alcohol withdrawal that would indicate a genetic component, those with a history of alcohol withdrawal, and individuals who are also consuming sedative, hypnotic, or anxiolytic medications. Conditions such as fatigue, malnutrition, and depression can also predispose an individual to developing an alcohol withdrawal. Now let's talk briefly about the pathophysiology of alcohol withdrawal. The symptoms of alcohol withdrawal occur primarily because alcohol acts as a central nervous system depressant. It simultaneously causes 2 effects. It simultaneously enhances inhibitory tone via modulation of GABA activity, while at the same time inhibiting excitatory tone via the modulation of glutamate activity. The constant presence of alcohol is what preserves homeostasis in the brain. However, abrupt cessation of or reduction in alcohol intake can unmask these adaptive changes that have occurred due to chronic alcohol use, thus resulting in central nervous system overactivity and withdrawal symptoms. What's the clinical course of alcohol withdrawal that we typically see? Symptoms of alcohol withdrawal generally appear within 6 to 24 hours of cessation of alcohol use, or after an abrupt reduction in chronic alcohol use. It is important for clinicians in an emergency or hospital setting to recognize that alcohol withdrawal can occur before the blood alcohol content, or BAC, has returned to 0. Initially, within 6 to 36 hours of cessation or sudden reduction in alcohol use, patients can have minor withdrawal symptoms, and these can include anxiety, restlessness, insomnia, headaches, diaphoresis, palpitations, anorexia, and GI upset. Physical signs on examination can include tachycardia, hypertension, hyperactive reflexes, and tremor. It is important to note that patients with mild withdrawal will have no changes in their mental status. However, these patients may still go on to develop more severe withdrawal symptoms. It is also important to note that patients who develop these more severe withdrawal symptoms may not have a mild withdrawal phase. So some of these severe withdrawal symptoms can include, first of all, alcohol withdrawal seizures, and these can develop within 6 to 48 hours of cessation or reduction in alcohol use. These seizures can occur in up to 30% of patients in alcohol withdrawal. They are generally a single or a brief flurry of stereotypic generalized tonic-clonic seizures with a short post-ictal period. Status epilepticus can occur, but it's very rare and it occurs in less than 3% of patients. There are a handful of risk factors for this type of withdrawal, including concurrent withdrawal from benzodiazepines or other sedative hypnotic drugs, low potassium levels, and low platelet levels. There is also a potential for a kindling effect to occur, and this has been observed occasionally, in which patients who have had alcohol withdrawal seizures have an increased risk of a repeated withdrawal seizure in the future. Seizures in well-known alcoholic patients should still prompt a workup for other causative factors, as these patients can still suffer from medical conditions. These could include head injuries, CNS infections, CNS neoplasms, cerebrovascular disease, hypoglycemia, hyponatremia, and hypomagnesemia, which can all be associated with seizure activity. Another more severe withdrawal symptom is alcoholic hallucinosis. Alcoholic hallucinosis, consisting of visual, auditory, or tactile hallucinations with intact orientation and normal vital signs, can begin within 12 to 24 hours of cessation or reduction of alcohol use, and it usually resolves within another 24 to 48 hours. Common hallucinations can include visual hallucinations of bugs or other animals in the room. However, auditory and tactile hallucinations can also occur, including formication, or the sensation of bugs crawling underneath the skin. A third type of severe withdrawal symptom is delirium tremens, and this can begin later in the course of withdrawal, typically around 72 to 96 hours after cessation or reduction of alcohol use. Delirium tremens is characterized by a rapid onset of fluctuating disturbances in attention and cognition, in other words, delirium, and it can also include agitation, tachycardia, hypertension, fever, and diaphoresis. Several risk factors for the DTs include a prior history of DTs, chronic illnesses secondary to chronic alcohol abuse that can include cirrhosis and malnutrition, development of alcohol withdrawal while the blood alcohol content is still elevated, a CWAS score of greater than 15, and we'll talk about the CWAS scale later on, increasing age, recent misuse of other CNS depressants like benzodiazepines, and concurrent respiratory, cardiac, or gastrointestinal illness. The mortality rate for the DTs can be as high as 20% in this patient population, which can be reduced to a 1 to 4% mortality rate with proper treatment. Another subset of severe alcohol withdrawal is called severe alcohol withdrawal syndrome, and this is typically defined as the development of both alcohol withdrawal seizures and delirium tremens. Now let's move on to the evaluation of patients with alcohol withdrawal. The clinical assessment is the mainstay of evaluation for alcohol withdrawal, and there are several key goals that must be achieved in order to provide the best patient care possible. First, we have to evaluate for any acute medical problems that could account for the patient's presentation, or that could be exacerbating the symptoms of alcohol withdrawal and potentially explaining why the patient has recently ceased or reduced their alcohol intake. Second, we need to determine based on the presentation and the history what the appropriate level of care is for the patient. These options can include outpatient management, inpatient management, and an addiction treatment setting that could be non-medically managed or medically managed, or an inpatient management in a medical setting. And this is the most intense option available and can include the general medical floor or an ICU setting if necessary. So how do we determine which level of care is most appropriate for a given patient? There are several steps that the clinician can take. First, we should look at the likelihood of severe withdrawal in the patient, including the possibility of delirium tremens or seizures. Patients with a high likelihood of these complications will require withdrawal management in a hospital setting most likely. Patients who are more likely to experience severe withdrawal are those with multiple comorbid medical illnesses and patients with a history of severe withdrawal. Second, patients should be evaluated for medical comorbidities, including acute and chronic conditions that could increase the morbidity and mortality of alcohol withdrawal. Patients who have chronic comorbidities will likely require at least withdrawal that is medically managed in a detox program. Patients with unstable chronic conditions or acute conditions, for example, pancreatitis or pneumonia, will likely require inpatient hospitalization for management of their withdrawal. Next, we need to determine if it is likely that the patient will be withdrawing from more substances than just alcohol. If it is likely that the patient will withdraw from alcohol in addition to other substances, management in an inpatient medical setting may be warranted. And it's also important to keep in mind how much social support that the patient has at home. For example, a patient who has mild to moderate withdrawal with a very low likelihood of complications from that withdrawal, but who has a non-existent or poor social support system at home, may benefit from management in a non-medically managed detox program. In discussing the clinician's evaluation of a patient with alcohol withdrawal, the evaluation should contain some key elements. First, a thorough history of the patient's drug and alcohol use should be obtained. This can include the time of last use, the quantity and duration of use, and the method of use. For alcohol especially, it is important to ask about a history of complicated withdrawal, which could include asking about hospitalizations for alcohol withdrawal seizures, and delirium tremens. The patient's social history should include emphasis on the patient's social support network, including family and friends who can continue to encourage abstinence and potentially help with transportation to groups or therapy or other appointments and with medication dispensation. Identifying barriers to quality treatment is also important for helping determine the next step of care. Physical examination should also be comprehensive in order to identify any comorbid medical illnesses or conditions that could contribute to the current clinical presentation or may worsen the risk of complicated withdrawal. Neurological examination should also be performed to rule out any concurrent Wernicke's encephalopathy, as this condition requires specific treatment. Routine laboratory testing should be performed, and this should include a CBC, electrolytes including potassium, magnesium, and phosphate, glucose, creatinine, liver function tests, amylase, lipase, a blood alcohol level, a urine drug screen, and a urine HCG in women of childbearing age. EKG is also suggested in patients who are over age 50 or who have a cardiac history. It is also important to consider head CT in patients who present with a first seizure or with a presentation that is different from previous episodes of severe withdrawal, or if there is any suspicion of head trauma. There are also some tools that are available to help clinicians standardize their assessment of patients in acute alcohol withdrawal, and this can be very helpful as these patients are often evaluated by multiple providers throughout their hospitalization. One tool is called the Audit-C, which stands for Alcohol Use Disorders Identification Test Consumption, and this is a brief validated screening tool for risky drinking and alcohol abuse in patients. It can help clinicians to predict which patients are at risk for alcohol use disorder, and thus have a higher potential for alcohol withdrawal. Another scale that we use is the CIWA scale, which stands for Clinical Institute's Withdrawal Assessment Scale for Alcohol, and this is the most widely used symptom severity scale for patients with alcohol withdrawal. It can help determine the need for medically supervised withdrawal management in this patient population. In most alcoholic patients, if they have not had a drink for at least 5 days and their CIWA score is less than 10, they will likely not need any medical management of their withdrawal. CIWA scores can also be used to help provide adequate medication management in patients who are going through acute withdrawal, as the scale allows the clinician an objective measure of the patient's withdrawal symptoms and can be repeated at intervals, usually of 4 to 6 hours, to assess for improvement or worsening of the withdrawal symptoms. Now let's talk about the treatment for acute alcohol withdrawal. After adequately treating any comorbid medical illnesses, the goal of treatment of alcohol withdrawal is to alleviate symptoms and identify and correct metabolic abnormalities. The primary pharmacotherapy treatment for alcohol withdrawal symptoms are benzodiazepines, which can help control psychomotor agitation and prevent progression of symptoms to a more severe phase. Benzodiazepines can help to control seizure activity, delirium, anxiety, tachycardia, hypertension, diaphoresis, and tremor, and these can all be associated with alcohol withdrawal. The dosage typically should be titrated, starting at a higher dose and then slowly decreasing the dose as the patient recovers from the withdrawal. Generally speaking, the benzodiazepines that are long-acting with active metabolites are preferred as they can result in a smoother course of withdrawal with less chance for complications. Some of the more common benzodiazepines that can be used include chlordiazepoxide, which can be given intravenously for extreme agitation or orally for tremors or mild to moderate agitation. The IV dose should be 0.5 milligrams per kilogram, given at a rate of 12.5 milligrams per minute until the patient is calm. Oral doses should be 25 to 100 milligrams by mouth and can initially be repeated every 2 hours until the patient is calm, and then given every 4 to 6 hours. Another medication that can be given is diazepam, and this can be given orally for tremulousness or mild to moderate agitation, and it's dosed at 5 to 20 milligrams every 4 to 6 hours. It can also be given IV for withdrawal seizures, and that dose would be 0.15 milligrams per kilogram, given at a rate of 2.5 milligrams per minute. Lorazepam can also be given, and it can be given orally for hallucinosis at 2 to 10 milligrams every 4 to 6 hours, or intravenously for delirium tremens at 0.1 milligrams per kilogram at a rate of 2 milligrams per minute. Benzodiazepines should be given in sufficient quantity so that the patient is calm and somewhat sedated, but not so sedated that they cannot be aroused for appropriate clinical procedures, including neurological exams. Note that for acute alcohol withdrawal patients who may have advanced cirrhosis or acute alcoholic hepatitis, the recommended benzodiazepines for symptom management are lorazepam and oxazepam. In terms of the strategy that clinicians can use to approach giving benzodiazepines to a patient with acute alcohol withdrawal, there are two methods to consider. Some clinicians favor a fixed schedule therapy in which the patient is treated with the benzodiazepine regardless of active symptomatology preceding each dose. This favors the prevention of withdrawal in patients who have mild withdrawal and who are at risk for severe withdrawal symptoms. For example, in a patient who is just starting to withdraw and has a history of complicated withdrawal seizures or DTs. Other clinicians favor a symptom-triggered approach to therapy, and this would involve providing the patient with a medication dose only when they are having symptoms. This requires the regular use of a symptom severity scale, most commonly the CEWA scale, as previously discussed. Scores over 8 indicate moderate to severe withdrawal and would warrant treatment with pharmacotherapy. And it's important to note that the research more recently is showing that symptom-triggered treatment is more advantageous as it allows for individualized treatment for the patient, decreased treatment duration, and also decreased cumulative dosage of sedative agents that are given to the patient. Studies have also shown that several other agents can be helpful in the treatment of alcohol withdrawal, and these agents do have the advantage of minimal abuse liability. First of all is carbamazepine, and this given in doses of 800 milligrams daily has been shown to be as effective as benzodiazepines in withdrawal treatment. Another agent is clonidine, and this has also been used to block symptoms of sympathetic hyperactivity. Keep in mind that neither of these drugs, however, is effective for the treatment of seizures or DTs. There is a small subset of the population that can display refractory delirium tremens despite large doses of benzodiazepines. In these cases, benzodiazepines and barbiturates like phenobarbital could be used in combination to alleviate symptoms. The recommended dose of phenobarbital in this case would be 130 to 260 milligrams via IV, repeated every 15 to 20 minutes until the symptoms are under control. Supportive therapy is also essential in alcohol withdrawal patients. Patients should be placed in a quiet, protective environment. Physical restraints may be a temporary necessity in patients who may be suffering from delirium tremens. Chemical restraint, however, is preferred to physical restraints, as physical restraints can lead to hypothermia and rhabdomyolysis if the patient fights against the restraints for an extended period of time. However, clinicians should keep in mind that antipsychotics are contraindicated in the treatment of alcohol withdrawal, as they can lower the seizure threshold, and thus they should not be considered when contemplating chemical restraint options. Further supportive therapy options include volume replacement with intravenous fluids, thiamine and glucose administration to prevent or treat Wernicke's encephalopathy, multivitamins supplemented with folate, the correction of any glucose, potassium, magnesium, or phosphate deficiencies, and also the fact that patients may require NPO status as they are at risk for aspiration. Sometimes a nutrition consult can be recommended as these patients are frequently malnourished and have high metabolic needs. And lastly, keep in mind always that ICU admission can be considered in patients who have a higher risk of complications from their withdrawal. When it comes to the more severe form of alcohol withdrawal that is delirium tremens, the best treatment is prevention. Patients who are withdrawing from alcohol should receive benzodiazepines for treatment of their symptoms until they seem to be out of clinical danger. If delirium does develop, patients should be treated with oral chlordiazepoxide or intravenous lorazepam if oral medications are not possible. As previously mentioned, antipsychotics can cause a reduction in the seizure threshold, and thus they should be avoided in withdrawing patients. In patients with DTs who are physically dangerous, a seclusion room is normally preferred to physical restraints, as they could fight against the restraints to a dangerous level of exhaustion, as previously mentioned. Dehydration, which can be exacerbated by fever and diaphoresis during the withdrawal period, can be corrected with oral or IV fluids. Non-benzodiazepine anticonvulsants are not useful in preventing or treating alcohol withdrawal convulsions. It is also essential to allow for warm supportive psychotherapy in treating these patients, as they are often frightened, anxious, and confused. That concludes today's episode. I would love to hear feedback on what you thought of the podcast, and if you have any questions or comments, please visit www.conceptsinpsychiatry.com. Thank you for your continuing support of this podcast. This show is hosted, recorded, and produced by myself, Dr. Sarah De Leon. Information on all reference materials used to produce this episode can be found by visiting www.conceptsinpsychiatry.com. Thank you.
If you enjoy this content, don't forget to like, comment, and subscribe. Share this video with someone who may need it. For more information, visit peoplewithalcoholism.com. Follow People with Alcoholism on Facebook, Twitter, YouTube, Instagram, and Pinterest for additional support and inspiration. Our blog is intended to inform and support you during alcohol recovery.